Resources, economics, it's not the most important part of the topic, of course, but it's an essential part of any discussion about better policy, better practice, better lives. So we're going to get to some of those policy issues now. So when we're considering a new policy, a new preventive strategy, a new treatment or support program, there are a number of common economic elements that come in, or economic questions that get asked. One of them is, what does it cost? What does it cost to implement this preventive strategy or whatever it may be? And that's not just cost. I mean, the session is called Health Economics. I prefer to sort of cross out the health and just say economics. What does this cost across different parts of the public policy area, across the whole of society? So that's one question. The second question that gets asked when we think about a new policy or program is, okay, what does it cost? Will it save any money? What does it save? What savings are generated? In particular, does it save real money, cashable savings? And many healthcare systems across the world are under tremendous resource pressures. That becomes a key issue. And then the third related question to that is, okay, so if it doesn't save money, might it still be worthwhile in an economic sense, in a societal sense? So the outcomes, the things we achieve are good enough to make it worthwhile to pay that money to achieve them. So those three questions are typical economic evaluation questions, and we'll hear some of that from David in a moment. We also want to know how to pay for these things. How do we pay for these services or these responses or these strategies? And that takes us into a world around insurance and taxation and universal coverage and reimbursements to providers and so on. That's also an economics question. Another big economic question is whether there are economic causes of mental illness or complicators, poverty, unsecured debt, employment difficulties, inequalities, and so on. Those all have economic components, and so that's another thing that people like me working in this area would look at. And then mental illness, we know, has influences on our ability to achieve some of the economic goods or benefits that many of us enjoy, a good job, a decent income, and so on. So another connection there. So there are many, many other economic issues. We can't cover them all. I think we have to remember this session is an opportunity to get realistic about resources, and that's what we're going to hear from the three speakers. Now, before I do introduce them, I just want to make a comment. This is, at this conference, the only all-white male panel. And we did try to make sure that wasn't the case. We should do better, and I apologize if I'm culpable in that, but I hope nevertheless you'll get something beneficial out of the session. So I'm first going to ask David to come up, David McDaid from LSE.
Right, hopefully somebody's going to turn my slides on. Are they going to appear by magic? Wow, they do. Right, okay. Right, good afternoon, everyone. As Martin says, it's always difficult to get things going after lunch, but I hope that in the few minutes I have, I can try and really emphasize that even if many people in this room are not interested in economics at all, that it really can make a difference when you're trying to make the case to different kinds of policymakers, service providers, and indeed more broadly beyond health and mental health systems. Because whether we like it or not, money arguments do talk, and they talk in all contexts, not just high-income countries, but also in low and middle-income countries as well. So I should say that, most of my work is around the economics of early intervention, the economics of mental health promotion. And I'm going to focus today specifically on some of the economic arguments for tackling, as what Graham Thornycroft said yesterday, was the scandal of the difference in life expectancy between people with severe mental illness, and indeed actually all sorts of mental illnesses, and that of the general population. And I want to start by arguing that you can use economics to go actually hand in hand in this case with moral and human rights arguments for investing in mental health. And first of all, I just wanted to point out, and I don't know if this is going to work well, is there a pointer on this? Maybe there is. Well, there is, but it doesn't work very well. Anyway, the point is, we don't live in a world of single morbidity. We don't live in that world. This is a slide from the UK, a detailed analysis of one particular part of England. If you can see the data there on mental health, there's only a minority of people in the specialist system who have one condition. People are living with multi-morbidities. Multi-morbidities are the norm. So why do we always think in terms, well, we don't always think this way, but we often think in terms of single conditions when we're thinking about treatments and certainly about economic arguments. Martin and myself were involved with colleagues from the King's Fund a few years ago now, where we did something that was relatively simple and it's large number type based analysis, but basically just trying to flag up the point that there is this interaction, this intersection between people living with long-term chronic physical health problems and people living with mental health problems. And we estimated roughly between 12 to 18% of expenditure in our English National Health Service is linked to poor mental health, or about $1 in every 8, if you want to use dollars. So there's this overlap. These conditions are not in isolation, yet many systems separate out mental health service provision from physical health service provision. And I would go further than that to say that we need to do more in terms of economic arguments to argue, to demonstrate what are the excess and crucially avoidable costs of multi-morbidity in people living with mental health problems. And that's something that health economists have looked at in the past, but we haven't looked at it anywhere near as much, I believe, as we should do. And yet there are studies out there. Chris Cornell and colleagues in the States have been looking at the impacts of cardiometabolic comorbidities in terms of healthcare costs within the system. And it's not surprising to see that as individuals have more comorbidities, their costs, both medical and drug-related, for schizophrenia and bipolar increase. And that probably doesn't come as a surprise to anyone in this room. But yet it's something that doesn't get looked at enough. And the question is, if we invest in better protection both of mental health but also managing an early intervention for physical health, can we avoid some of these comorbidities or reduce their impacts? It's not just about health systems as well. This is an Australian study, and what it shows, it shows that it's a survey, general labour force survey, some people living with cardiovascular disease, some people living with major depressive disorders. And it shows the likelihood of being in employment if you have one of these conditions or both of these conditions. And I've circled in red there the fact that the odds ratio, the likelihood that you are in full-time employment, if you have both a cardiovascular disorder and major depressive disorder, is 0.4 compared to a 0.8. in a sense, for people who have just one of these conditions. So multi-morbidity, comorbidity between physical and mental health issues increases arguably productivity losses to employers and therefore to society as a whole. And we did some crude work, and I do emphasize this as crude work, in Europe a few years ago, looking at the potential excess costs, physical healthcare costs, associated with schizophrenia and bipolar disorder and major depressive disorder in the EU, building on work that had previously been done by the European Brain Council to estimate the costs of brain disorders in Europe. And crudely here, this slide just shows the excess costs for physical health problems associated with the increased risk of having diabetes or cardiovascular disease if you have schizophrenia. So, and this is across the whole of the EU, but it's a lot of money. And we don't need to worry about the size of the numbers, but they're big. And the question is, can we avoid some of these? And what you will see here for both diabetes and CVD, there are substantial costs to healthcare systems, but a lot of costs outside of healthcare systems as well. And even a small impact in terms of actual genuinely avoidable costs could be potentially significant to healthcare and indeed wider welfare systems. We also looked, as I mentioned, at these other disorders, bipolar and depression as well. And you can crudely see here, these in terms of hundreds of millions of euros, which is roughly the same as $1 these days. I think that's right. Maybe I'm wrong. Anyway, don't ask me about that. Anyway, but this is the cost of excess morbidity. And I should emphasize, this does not include the costs of premature mortality. So if you add those costs in as well, then the numbers are even larger. This is just morbidity. And the reason we did this, and again, this may be an unfair thing to do, but we sometimes, or at least I take the view sometimes, that there are lots of people out there who aren't interested at all in mental health within healthcare systems. That's probably heresy, but I'm just going to say it. but they are interested in dealing with their budgetary issues, dealing with challenges to the physical health side of things. So if you can improve physical health, improve cardiovascular health, reduce cost to the physical health system in that kind of crude sense, actually people listen, even if they're not actually interested in mental health. And despite what people say, I think some people aren't that interested in mental health, and that's a bit of advocacy rather than academia, but nonetheless. Now, the problem or the challenge with all of this, and you could show lots and lots of data on costs, and lots of big numbers, and people get skeptical about big numbers. It's only really worth the paper it's written on, in a sense, if you can do something about it. So we have to know, are there effective interventions out there that can help to deal with physical health risks for people with mental health problems, and equally from an economic point of view, is it cost effective to do so? Myself and my colleague Ala Park and other colleagues from around Europe participated in a European program a few years ago looking at promoting the physical health of people with severe mental health problems. And we did a review of economic analysis, and this is about 2013 when we did this review. And in short, we didn't find that much, really. A few studies around smoking cessation, HIV, TB, substance abuse, but not a large body of evidence. And we were arguing at the time there are opportunities to further strengthen the evidence base. Now, Graham and others yesterday were talking about the new wonderful guidance that's come out from WHO, and looking very quickly, very crudely at the reports and just looking for the word cost in the report and the background document, it doesn't appear that often. And that's not because it was an overlooked issue by the group producing the report, it's because they weren't able to find very much evidence. So again, there are challenges here. But that's not to say that there aren't things out there at all, and I'm not going to go through all the evidence today. There's no time for that. And anyway, it's just to flag up that you can find economic arguments, albeit with lots of caveats around smoking cessation, around medication management, about lifestyle management, weight management, some things around motivational interviewing as a technique for these kinds of things for group and individual exercise programs. And there are people who could talk much better about that than me. But the evidence is mixed. But I would argue there are challenges about how it's actually implemented as well and evaluating the implementation process. So you can't just look at costs and cost effectiveness alone without looking at implementation as well. And a lot of it, well, basically all of it pretty much, is from high-income country contexts. So that's the challenge as well, to increase what we know about early intervention, prevention, better links between physical and mental health in low and middle-income countries. But there isn't another important point of, this is a call in a sense for people who work in economics, or those of you who have done work in physical health more generally. What about adapting the literature and the knowledge that we have on the benefits of better physical health for the general population and looking at that more specifically for people with mental health problems, because there is a broader evidence base on that. And I think sometimes that, okay, there are differences and there are adaptations that have to be made, but it's something that could be looked at more often than it is. Just a couple of quick examples. Recent study here from Meenan and colleagues, which is an American study, which was looking at a multi-component lifestyle and weight management program. And what they did find, actually, it cost about $4,000 US dollars to implement this program, but it did generate savings to the healthcare system of about $1,000 a patient. But that's obviously a lot less than it costs to implement the program. But I would point out that these are costs for a one-year time period, and that one of the challenges we also have is, can we see if we can improve and maintain physical health in the short term, can we have longer-term evidence? Can we look and see what extra efforts are needed to sustain positive behavioural change, and what are the benefits of those long-term sustained behavioural change? Now, you might think that's kind of difficult to do, but let me say this. The OECD have published an enormous number of reports recently looking at the benefits of investing in prevention and promotion generally. And they have 50-year timescales where they look at the benefits of lifestyle interventions and weight management and exercise, and they do these 50-year timescales, and they produce those reports. And despite all the limitations, they do have an impact, or the assumptions that have to be made in models, they have an impact with policymakers. So perhaps we should learn something from their book as well. Well, that's an interesting slide. Let's not worry about that, other than to say that some of this is not new. It doesn't look like that on my slides. I swear it doesn't. But anyway, it's probably animation. It doesn't like animation. But the point is, the late, great Wayne Caton, Professor Wayne Caton and colleagues in Washington State have for years been demonstrating that there are economic benefits to investing in collaborative care for things like depression and diabetes, where you can see the benefits in terms of improved glycemic control, improved diabetes control, and reduced costs in terms of the management of diabetes. So some of this is not new. Was this frozen now, actually? Oh, no, there we go. But some of this requires better collaboration and cooperation with primary care as well, and that's something economics could look more at. There's lots more out there, not going to talk about this, but there are modelling studies out there now starting to build a case. So sometimes they're not linked to trials, it's about taking limited evidence and building models about potential long-term impacts if interventions are delivered as they have been seen to be delivered in small-scale studies. I will mention two other things. One is that, in terms of evidence, one is that there's been some recent analysis in the UK about healthcare checks for people with severe mental illnesses. And this has been conducted at the University of York, and it's been implemented in a number of local health systems in the north of England. And what they found there is that actually the implementation of these primary healthcare checks do actually lead to some costs being avoided within the healthcare system, the secondary healthcare system. And they've estimated that if this was scaled up to the whole of that particular region, that there are substantial savings to be made. So, but that's the first study of its type that I've seen in England, and I haven't seen an academic peer-reviewed paper on it, but I have seen a credible report from a university consultancy on that. Work that I did with Martin and others looked recently for our public health agency, national agency in England. We tried to identify some of the initial and immediate arguments to support investing in mental health promotion in local governments. Because in England, lots of decisions about mental health promotion take place within local governments, actually rather than within the health services. It's a complicated system. But the point here, there's two things to flag up about this. One is that we looked at a lot of different areas, including physical health, which I'll talk about in a minute. But equally, our brief, in a sense, from governments was make arguments that are going to resonate with the people who actually have the money. So if the arguments are for local government officials, focus more on the impacts on local government budgets rather than necessarily on impacts on the health service, or at least flag them up and make people aware that there are benefits to be achieved. And the same with education. We looked at children's outcomes, for instance. Benefits to the school system of better mental health in young people. You can flag those things up as well. But so we have this model, and it looks at what are the potential returns and investments for investing in some of these interventions across local government areas in England. And one of the areas we looked at, building on some of the evidence that is published from trials now, is around collaborative care. Collaborative care for people with a serious mental health problem, usually major depression, but it could be bipolar as well in the model, and the impacts it has in terms of cardiovascular management and diabetes management. It's a short-term model because we didn't have long-term evidence. But what we do find in the model is that over 2 years, you generate a return of about $1.50 for every dollar you spend. Some of that is within the healthcare system, some of that, but most of it, in a sense, is actually about impacts in terms of participation in work or other social activities. So promoting and protecting physical health helps people return to or remain in or recover and go back to their other productive activities, which can include, by the way, volunteering. It doesn't have to just be about paid work. But the point here is that we look at these issues and we try and make arguments that government and policymakers can actually use. One slightly different example, because we struggled, as I say, when I was looking and preparing for this talk, I was really struggling to find anything on low and middle income countries. And I then thought, well, so, quoting your own work is always a dangerous thing to do, but it's work that I was honoured to be a very small part of that was led by Vikram Patel in India, and this was the Premium study, which was a study looking at the use of community healthcare workers and their role in actually managing both major depressive disorders, but also harmful alcohol disorders in India. And we did a cost-effectiveness analysis over a 12-month period. We collectively, the group, but myself and my colleague Ala Park from the LSE did the economic analysis. And what we found, essentially, and this looks a bit complicated, but you don't need to worry about it. On the right-hand side, essentially, if this pointer thing works, and it probably doesn't, on the right-hand side, as I'm looking at it, over there, where it says societal perspective, you've got lots of dots in that sort of southeast quadrant. That basically means you're likely to get better outcomes and lower costs. as a result of investing in intervention delivered by lay community health workers using a brief psychological intervention to manage harmful alcohol behaviours in India. The point here is that obviously alcohol has an impact on physical health, and more work needs to be done of this type to demonstrate those physical health benefits as well. But we did in our analysis look at all contacts with the healthcare system, regardless of whether that was for alcohol or other use, and that did fall in that particular intervention group. I'm conscious of time, and I know I've got about 3 minutes left, but no more than that, 2 minutes left. Okay, so the evidence base will grow. In looking for things, I did find, for instance, studies from places like India, from places like South Africa that are now ongoing and evaluating integrated physical and mental health services. So the Kowalski and colleagues, I think from Johns Hopkins in the States, are working in India to look at diabetes and depression. Professor Crick Lund and colleagues from Cape Town in South Africa are looking at different ways of managing physical and mental health in a community. And I'm also involved in a project in Bangladesh, India and Pakistan, looking at how we can develop and put more emphasis on physical health for people with severe mental disorders. And there's a totally unnecessary slide with a picture of me and lots of other people who are going to be working in Bangladesh, and India and Pakistan. Impact project. One final thing in my 1 minute I've got left, and that's just to say something that's not controversial, but not to overlook. All of this is about, all I've been talking about, and a lot of what's been said at the conference has been about things we can do within the mental health system to promote better physical health. But I also think we need to integrate more with those more broad efforts to promote public health, essentially. I mean, this is Once Life in Scotland. You don't need to worry about the detail of this, but what it basically says is people with the highest levels of deprivation have the highest levels of physical health problems when they have mental health problems. So there's a socioeconomic gradient of multi-morbidity in a sense, and not all of that is dealt with by health interventions. It's about social welfare, it's about education, it's about restricting access to unhealthy products for the whole population, change the level of salt and sugar and so forth in the diets. Lots of things out there on that. We did a book in it, but lots of other people have written on this. The OECD again, World Bank, evidence on what works in terms of physical health promotion. And I think we should try and put mental health interventions or interventions to promote the physical health of people with mental health problems into that broader context as well. The WHO have done great work on this with Best Buys, which they look at economic evidence, looking at the benefits to physical health of various things around sugar in this case and salt intake for diets. The point is here, we're not expected to do this within the mental health world, but we should argue that in countries where these things aren't in place, more efforts should be made to generally promote public health, health promotion as well. So intersectional actions are important. Another spurious, unnecessary slide for me of work I've done on intersectional activities. But the point is, it's not just about the health system, it's education, welfare, making arguments to other sectors as well. So to sum up, and I know I've gone far too quick and shown far too many slides, and that's always a dangerous thing to do. But honestly, there is a way in which we, from the economics world, can demonstrate there are additional and potentially avoidable costs of physical comorbidities for people with mental health issues. The moral and the economic arguments go hand in hand. The economic evidence base is small, but it's growing, and there are opportunities to strengthen it. And that is happening in both high, low, and middle-income countries. And I also think as well, we need to have our policy and advocacy hat on to make sure that we embed everything we do to promote healthier and longer lives for people with mental health issues within a broader context of investing more in public health and health promotion and changing the obesogenic or the environment around us, because that has an impact on not only people with mental health problems, but everyone else in society as well. And we need to do as much as possible to link these issues together. But I hope that's helpful a little bit. And just to say, don't be afraid of health economists. We're here to help, and we're here to speak the language that you speak as well, so thanks very much.
So I too want to thank Fountain House and the other organizers and sponsors for organizing and hosting this event, and also for making room on the panel for some health economists. There aren't a lot of us working on mental health issues, but I think our field can make useful contributions in advancing the goals of this meeting, especially in partnership with folks from many other disciplines. So maybe we'll convey a sense of that in the course of the hour. I'll reassure people, I'm regressing to the mean in terms of slides. I have 0. I do have notes, so forgive me for that. If I can speak without notes, but then I'm even more verbose than when I speak with notes. I am obligated, this is a housekeeping thing, to offer the following disclaimer. I work at the National Institute of Mental Health, which is part of the Federal National Institutes of Health in the United States. The comments I'm about to give are mine and may not reflect those of my employer. Please take my word for that. I was asked to comment in this session a bit on the topic of mental illness and work. But first, an aside. The most common statistic invoked yesterday morning was that people with serious mental illness have lifespans a decade or two shorter than people without. Now, I had the opportunity, actually, with using some data that I think Richard Frank, the next speaker, had a hand in, a data system, had a hand in creating, to do analyses and publish results a few years ago documenting that in the United States, I did it. Self-induced injury. So I'll repeat. We published a paper a few years ago documenting that in the United States, there is extraordinary excess mortality even in the first year after initial onset of symptoms. In particular, among young people who receive a new diagnosis of psychosis, within 12 months of that first diagnosis, this was a population cohort in the United States of people with commercial insurance. They were not uninsured, and they were not also on the Medicaid program, which is for people, for low-income people or disabled people in this country. So for such young people, within 12 months of that first diagnosis, at least 2% of them were dead. They were dying, these were people in their teens and 20s, they were dying at the rates where if you want to look for a group in the general population with similar mortality, you have to look at people over age 70. So these are life-threatening conditions from when they first start, and not just after years of heavy smoking or after poorly managed chronic physical health problems. I mention this not just to cite my own work, although, two other points. First, it highlights the importance of routinely tracking mortality as an outcome among individuals with mental health problems or in relation to index psychiatric events. So far, being alive is the only biomarker we have in psychiatry, but we don't so far track mortality as an outcome routinely in people with mental health problems. The cancer community does routinely, the heart disease community does routinely in this country. Every heart surgery program in this country tracks and reports post-discharge mortality on heart surgery patients, and 60% of them report the results by hospital publicly in Consumer Reports, the consumer information magazine in the United States. In this country, one cannot look up a single published statistic on a population basis of the 12-month survival rate of people with an event like coming to an emergency department with intentional self-harm or accidental overdose, or being discharged from a psychiatric hospitalization. And only 2 years ago, I and now Greg Simon and others did it a second time with a different cohort. Could we do it for people with a new diagnosis of psychosis? but we improve what we measure. That, by the way, is, among other things, an insight from economics. Microeconomics is broadly about how people respond to incentives, including, but definitely not only, financial incentives. So we should measure this. Second, the limits of making a narrow economic argument for improving mental health outcomes. I want to highlight that this research points to some limits of making such arguments. Put crudely, death can be cheap from a health system perspective. So if the bar we need to clear is that our services be cost neutral, let alone cost saving, we will often not meet that bar. In effect, we will let people die of overdose or suicide or whatever else. I mean, I'm not saying that we should, but depending on the sort of the narrowness of the framework by which one evaluates these things. Much of healthcare is in fact about improving quality of life. We recognize that in most of the rest of medicine, and we should emphasize it here too. Which gets me finally to what I was supposed to talk about, which is mental health and work. So obviously, I don't have to tell anybody in this audience, mental disorders are often disabling. Now, in some situations, effective mental health interventions can be undisabling. This was actually my original point of entry into this field when I arrived at the Rand Corporation in 1997. I had the opportunity to be the economist on several randomized control trials of the collaborative care model to address depression and other common mental health issues among people presenting in primary care settings. For working age people with depression, collaborative care not only doubles the rate of remission, it also improves people's labor market outcomes, and for the patient and for society, and in some cases, depending on the framework, also for the employer, the economic value of those benefits can more than offset any additional healthcare costs, but such benefits and even such outcomes are often not within the analytic scope of randomized control trials or other kind of research testing the effectiveness of medical interventions. And when that happens, in essence, we're stacking the deck against finding positive outcomes because we do a kind of exhaustive job of measuring the cost of delivering the interventions. That part is okay so far as it goes. But then we do an inadequate job of measuring the full scope of outcomes. Vikram emphasized yesterday, and other people here too, of course, patient-centered outcomes. And patients care, obviously, not only about improvement in their symptoms, but also in their ability to function, and that includes work function and school function and social function and living independently. But clinician researchers often don't know how to measure those outcomes, so a pitch for working with economists. But that happy story that I just described is also not always the case, so I want to be transparent about that. For instance, for people with serious mental illness, such as psychotic disorders or bipolar illness, there's a very large body of evidence documenting the benefits of what we here at least call supported employment. So it's a sheltered employment model. And especially for younger people also of an analog in education, sheltered or supported education. The evidence shows consistently that this is clinically beneficial and it can substantially improve people's quality of life. What supported employment programs do not do, based on current evidence, is enable people who are disabled due to serious mental illness to return to competitive employment. I mean, there are, of course, individual cases where that is true. These statements that I'm making based on research are true for on average or for overall effects. So So I want to be realistic about this. The evidence is very clear that supported employment should be part of comprehensive intervention programs to improve the lives across many dimensions of people living, say, with schizophrenia. But we should not imagine that we should not expect regularly that they turn people who are disabled on the basis of these conditions to be undisabled so that they can somehow exit public benefit programs. And in fact, that finding is one of the reasons why it could be counterproductive and even cruel to impose work requirements as a condition for receiving public assistance programs, like the Medicaid program I mentioned before, the US health insurance program for people with low income. Richard Frank, again, the next speaker, and his colleague Sherry Gleed address that particular issue of work requirements as a condition for public benefits in detail in a recent commentary in Psychiatric Services. Still, as a corollary to my point about tracking survival as an outcome, I'll repeat, we should also track people's labor force behavior and also their non-market work, such as informal caregiving. As outcomes of mental health programs and interventions, it's not enough to track clinical symptoms and then somehow assume that other patient-centered outcomes will necessarily follow from improvements in clinical symptoms. Thank you. I'm done.
I assume that it's revealing to all of you that economists have the type of social skills that you've just seen. My name is Richard Frank, and I'm going to be talking about how decision-making economics and decision-making around policy, particularly, make use of evidence. And I'm going to draw on my perspective both as an academic researcher, but also as somebody who spent most of 5 years of the 8 years of the Obama administration in a policymaking position. So economists and clinical researchers and advocates all develop evidence, and we've heard a lot of it over the last day and a half. Virtually everybody who's come up on this stage has brought with them some evidence and advanced an argument based on that evidence. And they're all aimed at providing service and support for the idea that people with mental and particularly serious mental illnesses should have improved care and support to let them prosper in their lives. In many cases, important impacts are discovered, and the researchers and the advocates who are sort of behind them become the champions for those programs, and many times this leads to frustration. For the academic, they can't imagine why their brilliant idea hasn't been adopted by everybody in the world once they've published it. For the advocates, it's a different kind of frustration in that they see a path to an improvement, and somehow people aren't smart enough to figure it out and agree with them and take it up. The mental health field, like many others, has many examples of this. The limited adoption of the collaborative care model, which we've heard quite a bit about just now, is one example. A second one is the slow and uneven diffusion of the IPS, or the supported employment model. And then most recently, and sort of most front and center today, is the challenge of implementing early intervention programs. Now, I want to offer some perspectives on how policymakers views the kind of evidence that is typically brought to this and how it gets incorporated into decision making. My focus is going to be on 3 points. One, efficacy and evidence and effectiveness are different. Second, policy infrastructure and implementation matter. And 3, there is a political economy of budgets that in many respects conflicts with the kinds of evidence and the kinds of thinking that economists and others bring to the table. Now, a policymaker, even one trained as a researcher like me, necessarily looks at the world differently from the scientist or the advocate. And I think the metaphor that perhaps best captures this is that of the fox and the hedgehog. How many of you know that one? Isaiah Berlin, right? Yeah. Well, the fox and the hedgehog, the fox is this creature that's always looking around, knows a little bit, always trying to figure out things from different perspectives to act on. And the hedgehog has a very focused worldview and sort of lumbers towards an end that way. And so the policymaker is the fox, and the researchers and the advocates are the hedgehogs. Hold that in your minds. So let me talk about each of those points. First, let me talk about efficacy and effectiveness. So efficacy is established by the kinds of trials that David and Michael referred to, where you have controlled conditions, where you can study something and you can get a clean result that scientists will agree is persuasive. And typically what is happened is that the intervention is implemented more or less the way it's supposed to be. It's applied to the populations that are most likely to benefit from the intervention, and it's done in an organizational context that is set up and prepared to deliver. Effectiveness happens in the wild, right? Effectiveness is bringing an intervention and letting it loose into the wild. And that is very different. So that means that if populations differ from the experimental populations, the populations that actually received the treatment differ from that where the experiment happened, there's going to be potentially a difference in outcomes. If the training of the workers that are delivering the care is different from that in the clinical trial, you can get a difference in outcome. And if the workflows in a clinic are different from that in the academic medical center at a place like Harvard or Pittsburgh or Yale, then your community results are potentially going to differ. And so at that point, if those things are all different, the efficacy and the effectiveness start to part company. And policymakers worry about this a lot, because when they get evidence from a clinical trial, their first question is, okay, if I'm going to start shelling out billions of dollars, which I will never be able to take back again, am I going to get anything like the results that I'm being promised? And the evidence about this is very important. And so in a sense, this is a plea for not only bringing evidence about the trial itself, but how do you get from here to there in terms of making the implementation of the actual intervention work in a way that is slightly comparable to what you saw in the laboratory? And I think that is of critical importance, and it's very much about what's been referred to in the last day and a half or so about scaling up. For example, let me give you an example. The collaborative care model in the United States, 37 randomized trials on it. Virtually all of them show that it's cost effective. And yet it's terribly underused in the view of many. And for many years, and when I was in the government, people came to me all the time and said, oh, if you only set up a billing code, if you only allow 2 visits in a day, it'll all be taken care of. Well, we did both of them, and it wasn't. Okay? And so it would have been much more useful for, rather than speculating about what was going to happen, to bring evidence to what do you need to do to set this up so it's going to be on a path to success in the community. Today, we're in the midst of an exercise looking at how do we implement early intervention programs for first episodes of schizophrenia and psychosis. And we feel tremendous pressure because of the promising clinical results to actually get these programs up and running. The US Congress has set aside 10% of the mental health block grant money for doing that. And, but as they do that, and as the debate has gone forward, certain questions have come up that are going to be fundamental to whether actually this works in practice. One is, even though we know what the right package of clinical services are to apply when we found somebody, how do we find them? How do we engage them? How do we identify them? How do we bring them and keep them into treatment? We don't have models of that. And, but on the other hand, we can't wait because we need to get going. So what the result has been is that we've allowed states to do it differently and learn from their experiences what works and then bring it back, and then we'll iterate again. That is, I think, a good model for how this should be done. Now, a policy maker's ability to move forward depends on this evidence and depends on understanding what the right models are, how do we find people, and then how do we apply the clinical technologies. The last point I want to make has to do with budgets and what I call the political economy of budgets. Budget policy and cost effectiveness are not the same thing. I'll speak for the United States. In the United States, we have such a acrimonious set of debates about budgets that we raised the bar high enough so many cost-effective interventions never get to see the light of day because, in fact, there just isn't enough money for them. And it's not because they're not socially efficient, and it's not because they aren't worth doing. It's because we have a set of budgetary politics in this country that won't allow them to come forward. Now, that means that budgetary politics gets in the way of social efficiency. On-budget costs matter more than off-budget costs, even if the total costs are the same. Diffuse benefits matter less than concentrated benefits. So if you can show that this group is going to benefit a lot from something, you're better off because you're going to have a political constituency to fight for it than if something is spread out among a lot of different people. Third, there are all sorts of odd linkages that play into this. In the United States, most recently, this has come out in the relationship between mental illness and guns, where if you can show that linkage for any given level of cost effectiveness, you have a much better shot of getting something through that touches on that issue than other issues. So there's a political reality that should shape how the evidence is presented, how it's analyzed, and how it's brought forward. My closing admonition is that policymakers are foxes. They're always looking around from many perspectives. Researchers and advocates are hedgehogs and have their perspectives. The hedgehogs have to figure out how to work in a way that appeals to and is understanding of the fox's problem. And I think that's the way we'll make progress.
Okay, so we've got a few minutes, just a quick, if you want some quick fire questions, you get some even quicker fire, whatever, answers. Let's get people sitting up. So can I just, okay, we've got, come to the mics if you want to ask questions. So let's go with the first question.
So, oh, yeah, right, yeah, okay. Hi, so my question is on incorporating cultural differences within economic arguments, because throughout this panel has talked so much about putting values and numbers on things, but obviously there are other things in society that are is more difficult to put a number on. So it's I think maybe you can even compare it to like baking a cheesecake for people with very different preferences. So you have the shared understanding, the biscuit base of like mental health and early intervention, early treatments, early detection as you know, cost effective in the long run and very beneficial. But how about the differences in cultural practices, in religion, in stigma within different societies, which you could say, you know, forms the different toppings, how you want to bake the cheesecake or put it in the fridge, whatever, and how would you kind of incorporate that into the economic arguments to present to policymakers? Thank you.
Okay, so cultural and other differences. Who wants to chip Dave? Dave and then Richard.
Yeah, well, great question. I think one always has to be mindful of cultural differences and indeed gender differences as well, and age differences, all the rest of it. It links in part to what Richard's talking about, because trials rarely look at that kind of issue, and therefore if you're trying to implement something in the real world, it may not work. I'll give you a non-cultural example quickly: loneliness. Lots of work in the UK to tackle loneliness and the impacts. Most of the interventions that people look at, I would argue, are interventions that women are more likely to use than men. And that may be a controversial thing to say, but thinking about, are you actually going to engage with the population you want to is crucial. So we need to think about it, work with faith groups as well, understand, for instance, Islam and fatalism and mental health and all the rest of it that some religions have. I say that because of work I'm doing with refugees in Syria. So it's really important, and we don't look enough at those issues. But it's also about the size as well of the population, but it's important. Richard.
I'll give you a very brief example that has nothing really to do with mental health, but I think it's illustrative. When we were implementing the Affordable Care Act and trying to get people to enroll, we were doing a lot of randomized testing of messaging. And so we tried messages in Spanish on Latino radio stations and then messages in English on Latino radio stations, and all of us believed that the Spanish was going to be the winner. Turns out it wasn't. It was speaking the local English on the local radio that by far was the most effective message. Surprised, but had we not looked into that context, we would have never understood that.
Okay. Quickly, Michael.
So I'll say briefly, at a kind of egg-heady level, economics doesn't actually have very much to say about what people should want, how tastes are formed. Economics sort of says, given that somebody wants something or prefers something, what do you do from there? Now, stigma, though, is something that there is a ready economic framework for thinking about stigma and what you might do about stigma, because stigma fundamentally means people's behavior, how they react to other people or how they're willing to disclose about themselves are affected by the incentives of their environment. And if there are implications of, there are distortions in what people understand about the prevalence of illness, the risk that someone in your life will have illness that are a byproduct of stigma. And there may, in fact, also be kind of economic approaches to changing the incentives to reduce stigma.
Okay, thank you. I've got time for one quick question and one very quick answer, so please.
My question is sort of at the intersection of economics and public policy and maybe a little bit of ethics. It seems that there are proposals to provide more funds for mental health programs as a way of dealing with the epidemic of gun violence in this country, according to political leaders. But I think it seems to me, and probably many people in the field, the connection between the problem of gun violence and mental health is very tenuous. So given that as a field we're always starved for more money and are eager to get more grants any way we can, do you feel uneasy, or is there any ethical question about accepting more government funds for mental health services if it sort of provides a sort of an implicit endorsement to the idea that this is a solution to the gun problem as opposed to more gun control regulations?
I recuse myself.
I guess that one's for me.
I would just add a general. Go on, Richard.
Well,
Yeah.
I don't have Michael's problem because my political party is out of the administration. So I think you've pointed to the dilemma very, very well. I think it's very clear, and that is the trade-off. We have a resource-starved delivery system, and this is an avenue to bolster that. I think there is an uneasiness, but the uneasiness doesn't come so much from the ethical dilemma of why am I taking this money. The uneasiness for me comes, what am I going to be asked to do with the money? Because if in fact it's only going to be at, for example, building new forensic beds, then I'm really uncomfortable. If it's more generalized for we need to treat people, we need to treat them earlier, I'm good with that. And so to me, it's what are the details of the strings that are attached to the money that make me either more or less comfortable with it.
Okay, I'm getting the signal we have to stop. I do apologize, but we're all around, so do come and grab us in the breaks. Okay, thank you very much.
Excellent. Thanks very much to the panel for reminding us that we're not going to be able to affect the change that we all seek without understanding economic realities and economic imperatives. Economists are kind of a key part of that equation. And I like that we ended with Richard talking more about some of the policy implications of that, because that segues really well into our next and I think final panel discussion of the day. I'm going to welcome back up Kathy Pike to introduce everyone to talk about the policy and research agenda going forward and to restore some gender balance to the afternoon.
Oh, yes, coming. So we're just getting mic'd up here, and we'll join the stage. Everyone will come on stage as they're mic'd up. As we get started, yeah, everyone can just take a seat in whatever order you'd like. As we get started, I'd just like to make a comment about how grateful I feel to all of these panel members for joining in this experiment of asking them to listen carefully for 2 days and to reflect on what they hear and what they've learned and map that onto what they know from their home institution, their home country, their professional work, and share with us and reflect with us what do they take away in terms of priorities for funding, for research, for policy. And this is really what was at the heart of our thinking about this conference, was to bring together people who need to be talking to each other and who don't often have a chance to do so, and in the hopes that those conversations would spur new ideas and innovation and new collaborations and new paths forward, which is what Shekar will take up in the next round. The folks here are really doing the work and facilitating the work, and will be setting priorities in terms of research, policy, and funding. And it made me think about Pete Drucker, who is this extraordinary guru about innovation and change, who says there are 7 essential features that need to be present and that are part of innovation. One is the unexpected. And so we hope that in the course of the last 2 days, people have heard things they didn't expect, they couldn't have predicted. 2 is incongruities, recognizing that there is a gap between the needs and what exists. We know that's the case for our field. 3 is a market structure. Does the market support the innovation? And the example might be, for example, with the World Wide Web, there was an enormous amount of information that gave birth to Google, right? Google was able to be Google because there was so much scattered information. I think we have a similar moment in time in the world of mental health. 4 is necessity. I don't think I need to say anything to elaborate on 4. 5 is demographic. What are the components of human lifestyle, human needs, human desires that would support any of the innovation? We have heard it over and over and over again that in the case of serious mental illness, the human need for connection, for belonging, for purpose, the societal needs, the community needs are absolutely pressing and knocking on our doors. 6